this week on the Backtable podcast.
That's exactly what happens, right? You take away one pain, you unmask the other one, which is why it's so important to do the interview and do a really good physical exam. I would say spine, that's a lot harder because of the complex mechanics that there are in the spine with the discs and the ligaments and the shifting. But when it's like oncologic type pain or chronic abdominal type pain, complex regional pain syndrome, trigeminal neuralgia, long COVID symptoms, you can really do a detailed history and physical, which I know it takes time, but you can do a chart biopsy, you can do telemedicine, you can review imaging ahead of time to kind of consolidate that. If you put in the work up front, subsequent visits will be like 15 minutes because you had put in the work up front.
Hello, everyone. Welcome back to the Backtable MSK podcast. This is your host, Jacob Fleming. And with me today, once again, is Dr. Alexa Chevy to the Levey.
She's
back.
Thank you.
I think this is your third time on the show. And since the last time, you have made a move up to the Northeast. And so why don't you tell us a little bit about what you've been up to?
So never in my wildest dreams did I ever think a girl from Texas would end up above the Mason-Dixon, and certainly not in a state that I sometimes forget exists. Like Delaware, I always forget. Connecticut, sorry for those who live here. But yes, I did make a big move, kind of a career move and also a move for my family. I really, over the last, 2 years, I was in private practice after having moved from academics and realized what a mistake that was. And seeing the challenges that are out there with prior auths and insurance and doing what I do in the pain world and seeing that the only way to move the needle forward is to do the research that needs to be done, do the prospective studies, and realizing that I have to be at an institution that supports that. And never did I ever think that I would care about research. I always thought I'd just be doing cases and be so happy doing that. And I'm not somebody who likes to sit and crunch numbers. But when you find something you're passionate about and you have people saying, you changed my life, thank you. Or this didn't go the way it was supposed to, but I appreciate the work you're doing and I'm glad we tried something. Then you have that internal motivation to really try to make this something that everybody has accessible. And so there was an opening at Yale, and in the Northeast, there's a lot better schools. And I've talked about this, I think, before. I have 2 kids. I have a 3-year-old and a 6-year-old, and my son is severely autistic and nonverbal. And the resources in the Northeast are just so much better. And we wanted to provide him with every opportunity to succeed. And my husband was like, let's do it. And so he's actually starting at Yale too. So opportunity for urology and interventional radiology to maybe do some collabs. So a very, very exciting time, a lot of change.
Yeah,
it's been good.
That's amazing. Very, very exciting. We're very happy for you. And it's just really amazing how, like you said, it's hard to predict where your focus and your drive will take you. And that's really kind of the focus today. We talked about this quite a bit at SIR, and I think the session had a great reception. We talked about a lot of different things. And so you recently, with some now colleagues at Yale, have put out this really fantastic paper, which is common cryoneurolysis targets in pain management, indications, critical anatomy, and potential complications. And it's a fantastic paper. I got to read it last night for the first time. Just really well done, helping me prepare for some upcoming case of my own. And I think that there hasn't really been anything else quite like it. There's been a lot of papers on cryoneurolysis, but kind of hard to find, something that lays things down in kind of the standardized way. So could you tell us a little bit about the impetus for the article and what was the motivation behind it?
Well, thank you very much. I was very lucky to be able to ping Dr. Ann Saylor, who's one of our graduating fellows this year, who will be going on to train in pediatric interventional radiology, and Dr. Igor Ladich, who I know you've had on here as well. Incredible physician, funny guy, and very thoughtful. And I remember watching his podcast. I'm like, oh my gosh, we're so similar in how we think about this global approach to patients and this really, really, really tight physical exam. And so I was very grateful to be able to write this paper with them. The initial impetus to the paper, Dr. Merv Ozen reached out to me and asked me if I wanted to write a paper on this. And I was like, yay, great. So initial impetus, shout out to Dr. Ozen, and really appreciate her reaching out and giving me this opportunity. And she said, structure it how you want. And before I got into practice, even when I was at, UT, my first year out as an attending, I had only ever done one stellate ganglion block with Neil Resnick. I had done 2 celiac plexus blocks and an auriculorenal ganglion cryoablation with Aaron Cherry. And I had Dr. David Perlogo, and still do, as my mentor. And from that, here I am now. And so I'm nowhere near at any of their levels, but I've been able to kind of build and find my niche, and knowing to have people to reach out to, Alan Sag, and through the network, I'm doing this. How do I do this? And then realizing, when people now reach out to me, you do 10-8, 10-8, 10-8 for free. So I'm like, no, this is nerve. This is faster. We don't need to do that. We're just trying to create an injury to the nerve so it reboots. We don't need to kill everything around it. And realizing, I think, that there is a knowledge gap because it's not something that is standardized, and there's not a good paper on how to do it. And so we can't move forward unless there is standardization of procedures. And so the whole, again, impetus for me behind this paper was, let's try to make a how-to. Let's make a how-to do basic common cryoneurolysis interventions and talk about indications and the workup and talk about the freeze-thaw cycles that we use. And then also try to explain why we do it this way. I think a common misconception, and I see in my trainees, is that we're just taught, and also in reps as well. Reps are incredibly helpful, but the understanding that, number one, even for cryoablation, you need -22 to -24 to actually kill something. You don't need -40. So these huge ice forces, 20 ice forces to kill something, you don't need that. You just have to use your mind and say, okay, between this -20 and -40 is my kill zone. This is what I need. And kind of similar for cryoneurolysis, you just need -22 around that. You need to say not get any colder than -100, which is impossible with all the devices out there. And you just need to create a Sutherland type 2 injury, and you're targeting a nerve. A nerve is smaller than my fingernail, and my fingernails don't really have any. They're a little jacked right now, which is okay. I've got 2 kids. I'm busy. But they're really tiny. These are tiny, tiny little targets. And if you think about it like that, and you're just trying to injure it instead of killing a big tumor, it really kind of changes the landscape of what you're doing. And so I think that's the big point we wanted to get across, and then also kind of set people up for success. So give them a recipe for how to do these procedures, guide them for common indications, and kind of go from there.
Awesome. And I think you've definitely accomplished that. And it really gets into the nitty gritty on the individual ones, which I really appreciate. And, I think it does drive at some higher level concepts that we've been talking about as well, about, you trained at a place that, many would consider to be the modern mecca of cryoneurolysis. It is interesting just how many people have come from Emory. And, I think that kind of gets at the idea that, we do need to spread this and make it more replicable. And so tell us a little bit about your thoughts on, just getting this more disseminated as far as training goes.
Okay. Well, number 1, too, for those coming out of training, as I said, I did like 1 stellate, and now I've given lectures the last 3 years on stellates because I've done so many. And so I don't necessarily think that if you need to do a ton of these in training, you just need to understand the anatomy, understand the indications, understand the complications. Once you know the complications and you are sufficiently scared to cause stroke and hemorrhage and lifelong paralysis potentially, then the rest is image guidance, which is what we do. We do these hard things all the time. And so understanding neuroanatomy, understanding the different types of pain, which we talk about in the paper, it will help guide you towards what to treat. You don't actually have to do a lot of these in training in order to begin to treat these. And then you can start to reach out to people like I have. And my mentors have been very blessed to have a lot of them to reach out and kind of guide me on what I need to do. Again, there's also these, the paper talks a lot about all these plexuses, but something that I do a lot of, I know you also do a lot of like pain interventions with MSK, Dr. Ladich does a lot with MSK, but I also do a lot of like intra-abdominal interventions. So I do a lot of tumoral debulking when it's around nerves. So the same concepts apply and knowing how to do that. And so I think knowing who to reach out to and understanding the different types of pain is the most important thing, because then you can interview a patient and say, is it nociceptive? Is it nocioplastic? Is it mechanical? Is it neuropathic? Once you do that and can put it into a box, and then you have imaging to make a correlation and kind of make a formulation of a plan based off of a patient complaint in their imaging, then you can interview the patient and then you can intervene. And again, the whole idea is to get patients to a better spot. And I think I said this last time, just like when you break a bone, you're never going to get it back to normal. It's never going to feel the same. And so once you have pain, the patient will never be completely pain-free. And I truly, truly believe that. And I think it's a hard thing to say, and it's a hard thing for patients to accept, but someone has to tell them that. And if anybody's saying, I'm going to make you back to normal, you need to run far, 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 far away, because there is no magic wand to put you back the way you were. But there is a way to get you to a new baseline to where you can function. And I think teaching that to new attendings, teaching that to new residents and fellows, and that kind of concept when we intervene on people anyways for everything that we do. The famous kyphoplasty patient, you treat them and they feel great, but then something else hurts because of the mechanics on the back and the stress on the disc. And,
Right.
It's never going to be the same. But once you learn, I think that's a big part. And I don't know if it came across in the paper or not, but how do you talk to patients? How do you guide them through their new journey of how to function at a new baseline? And if you can get them to like a 50% improvement in their pain.
Yeah, it's so important, managing expectations. And I had a mentor who said that low expectations are the key to happiness, which sounds a little cynical, but actually I found that to be more and more true. And so, it's best not to promise a patient, oh, you're going to be pain-free, because like you said, that really does not happen. And actually, I've noticed that a lot with my kyphoplasty patients, is that they do great from the spine fracture point of view, but then they're like, oh, I got this other pain. I'm like, did that happen, after, or have you been noticing it for a while? I think I've had it for a few years, but you become more attuned to pain with, kind of an inciting event and those kind of things. And if we promise, oh, we're going to take your pelvic pain away or your abdominal pain away, and then they still have something, they may consider that a failure, whereas, they were at a, 7 to 9 before, and now they're at a, 3 or something like that. It's all about managing expectations.
100%. It's this unmasking that happens. And I always like to talk to patients about this, and I think it's a good reference. Have you ever seen the movie Major Pain?
No, I have not.
Okay. It's with Keenan Ivory Wayans. And the opening scene is there's a guy, he's a general or a captain in the army. And there's this soldiers on the ground, and like part of his leg is cut off or something's missing. It's been a while since I've seen it, but the what I'm going to say still holds true. And he's like, my leg. And he sees Keenan Ivory Wayans or Major Pain. He goes, sir, can you help me? Can you help me with my leg? And he goes, yes, sir, I can help you with your leg. And he takes each one of his fingers and does like this little piggy thing, and then his index finger, and breaks it in half. And so it's pointing the wrong way. And the patient goes, my finger. And he goes, well, you ain't thinking about your leg anymore now, are you?
Oh, no.
But it's just, that's exactly what happens, right?
Mm-hmm.
You take away one pain, you unmask the other one, which is why it's so important to do the interview and do a really good physical exam. I would say spine, that's a lot harder because of the complex mechanics that there are in the spine with the discs and the ligaments and the shifting. But I think when it's like oncologic type pain or chronic abdominal type pain, complex regional pain syndrome, trigeminal neuralgia, long COVID symptoms, you can really do a detailed history and physical, which I know it takes time. And I talked about this at SIR. Not everybody has that time, at 40 minutes that it probably takes to do a good exam. But you can do a chart biopsy, you can do telemedicine, you can review imaging ahead of time to kind of consolidate that and know that if you put in the work up front, subsequent visits will be like 15 minutes because you had put in the work up front.
Mm-hmm. Yeah, fantastic. So you do talk about the different types of pain in the paper, and you mentioned a second. Could you start by just kind of breaking down those different types of pain? That's probably one of the first things you're kind of thinking about when interviewing a patient.
Sure. So for me, I think we talked about nociceptive, nocioplastic, and neuropathic. And for me, I think about it more as neuropathic, nociceptive, and mechanical is a little more what I think about it. The mechanical pain, I'm thinking more bone, stress-related weight bearing. And when you get into that type, so that's kind of like one box. Nociceptive pain is pain that comes from signals from, say, like a tumor or a derangement of something that's happening. So somebody's had a lot of abdominal surgeries and they have chronic abdominal pain. And the chronic abdominal pain is from all the distortion of the mesentery and the organs on the inside and the stress that's put on that. Okay, so not so much from a mass, but like from the distortion and the signals and the stress on the underlying tissues and the signals those tissues are sending out. And neuropathic pain is pain that can be mapped to a nerve. So I have pain shooting down my medial thigh and part of my posterior thigh, that's obturator. It's neuropathic pain, and how it's described is different, So nociceptive pain can kind of be more of a vague pain, a visceral pain, described as more of like a pressure. Neuropathic pain, you think more about mechanical, shooting, stabbing, burning. And mechanical pain is more of a constant, I guess, pain, what people think of. And when they stand up or they weight bear, they have an escalation of pain, and it can be incited as well. And so also tagging on to that, you can also incite mechanical pain in a patient on a physical exam, as well as neuropathic pain. Sometimes if you touch it, nociceptive, it tends to be a little deeper and involved in an organ, and it's kind of more generalized. And so I think once you can put things into those buckets, you can know what to do. Also important to note, as I'm sure doing a lot of MSK interventions, when you have mechanical pain, we can do things like take away tumors, but you have to worry about stabilization. So before you do anything with mechanical pain, it's really important to have a good relationship with orthopedic surgery, neurosurgery, orthopedic oncology, so that they can help you with that. And I remember I'm going to touch on being in private practice, because you can do this in private practice. It was a lot of work to set it up. I had like a huge Excel spreadsheet of all the CPT codes and all the ICD-10 codes and multiple meetings with leadership about how to do this and how to bill and are we billing correctly and how to build out new Epic codes and make sure we had a CT scanner and then show them reimbursements, because that's the only thing hospitals understand. I didn't say that out loud, but I did. And, setting it up and doing it. So in addition to setting it up private practice, I was very lucky to be still a part of tumor boards. And I remember some of the tumor boards saying, this patient had, mets everywhere in their leg. I put it in a nail. They're still having pain. And I'm like, yeah, they're still having nociceptive pain. You fixed the mechanical portion. But you got to ablate the tumor that's causing the pain. And you could just push on the patient and do that. And so a lot of that involves education, with local tumor boards, which you can still do at the community level as well as at the academic level, and understanding and being able to explain, yeah, your patients probably feel a little bit better, after you put a nail in, and maybe they're also distracted by all their other pain, but you still left part of the pain there if the tumor is still there.
Mm-hmm. Yeah, so important. And it can get really difficult, especially in these patients with metastatic disease who have different sites of pain to really tease it out. And I think we also get into the issue of kind of goals of care of, we're not necessarily looking at local tumor control in a lot of cases, but more palliation of the pain. And so, if we have a somewhat complex situation, but a situation you see a lot, the patient who has a tumor, a rectal cancer with pelvic pain, and so you're consulted on a patient in this situation, kind of how do you start teasing that out? Because as you talked about, the pelvic pain is such a complex innervation, and it can be a little bit of a diagnostic conundrum.
Yes. So I'm going to touch on pelvic pain in a second. I want to come back to that because that neural network is tough and complex. And I'm going to start off with a more, I would say, almost straightforward patient where it's patient has metastatic disease. They can't get out of the hospital because of their pain. Readmissions for pain is a metric that's measured by oncology. So it's something really important to talk to your oncology colleagues. And sometimes patients just want to get home and spend their last, few weeks even. And how do you approach that? And my first patient I had was in Texas, and it was a young 40-year-old with metastatic cervical cancer everywhere, had massive lymphedema, could not really raise her extremities, her lower extremities, and was in so much pain that they couldn't get on top of it with a PCA and fentanyl patch and everything, that she couldn't get discharged to go home. And I was asked if there's anything I could do. And so talking with her about her pain, seeing it was mostly in her left lower extremity, shooting down, terrible pain, shooting, burning, and it was an 8 out of 10 and it was constant. Got a CT, saw that her tumor was going cranially and actually encasing the exiting L3 through L5 nerve roots, and we talk about pain palliation. And, just because there's tumor doesn't mean you have to go and kill it all. It means that you can go and maybe do some debulking to help get a patient home and to help them. And so what I did was, with a nice consultation from Dr. Proloco, because this is one of my first cases, is I took a bunch of ice forces for that and tried to kill as much of the tumor that was encasing those nerves as possible along that plexus, again, and being careful to avoid, collateral damage from other nerves. And that's something that I think people also don't think about, is how do you point your probe so you don't damage the sciatic nerve or the femoral nerve or other things. There's a lot of nuance, which is, I think, a whole nother topic. But I did that. I had a long conversation with her. You may not be able to walk after this. And she didn't care. She just, because remember, because those are motor nerves, right? You have to have a serious conversation with people, but I'll take care of your pain. You'll have some numbness and tingling. Also of note, when you reviewed her imaging, you could also see that some of her lymphedema was actually from venous obstruction. And so I remember one of my partners brought up, why not do a recan, this and that? And I said, because that's not going to improve her quality of life. She had, a few weeks left. And so that's truly what it's about, is improving a patient's quality of life. So I did that. Her pain was completely gone the next day, and she was able to go home. And that is the best gift that you could give somebody. And so that is a more general approach. Now, pelvic pain from rectal cancer.
You said this was probably the toughest thing you deal with, and I have to agree. This has been one of my first consults in private practice, and it's like, okay,
sorry.
Great. I'm glad I have Dr. Levey on speed dial.
No. I mean, this is the hardest thing. And you talk to, I was doing a lot more rectal cancer in private practice, and you talk to the oncologist, and pretty much every patient dies with severe pain. And the neural network is just so complex. I mean, you think about superior hypogastric plexus, inferior hypogastric plexus, sacral plexus, pelvic splanchnics, pudendal nerves, all the small branches, the perineal branch, the genital branch. Then you have, obturator nerve down there, and you have ganglion of impar. I'm just naming some things. And those are all targetable areas, but they all have small branch and interconnected networks that kind of surround the fat around the rectum. And, if you have, a uterus and everything else, the bladder down there. And so what do you do? It's hard. And anybody getting into pain, I'm sorry, this is your first consult. I would try to start off with a little more of a home run, like a stellate, which everyone's afraid of. But let's face it, we stick 22 gauge needles in aortas. We do suprahypogastric sometimes, and they're fine. They're fine. So you're fine sticking stuff in the neck. But I digress. So when you get a consult for a patient who's got rectal cancer and severe pain, the first thing I do is I make sure they have imaging, some kind of contrast enhanced imaging, and I look at it myself. And I'm already thinking in my brain, okay, is there tumor encasing something? Like, that is always pretty much going to be a home run. If you can focally do a palliative tumoral debulking in an area that is encasing a nerve, remember, like, the nerve injury you're getting is a Sutherland 2, which basically destroys the axons, but the whole nerve is intact. And the nerve will regrow the axons will regrow within 2 to 3 months, but that tumor is not necessarily going to come back. And so it can be a game changer for these patients. I had one patient who had really bad pain. I ablated the obturator in the pudendal, and she was pain-free, like palliative tumor debulking for 2 years. I saw her back after that, towards the end of my time at UT. She was really grateful to have time with her kids. So there's things to think about. So I look at imaging and I look for those areas of tumoral encasement. And then if there's areas of tumoral encasement, I say, what nerves are they? Are they motor? Are they mixed motor and sensory? Are they purely sensory? Is it going to make somebody incontinent? Are they going to have problems peeing afterwards? All these things go in my head because it's things that you have to bring up with the patient. And for example, some motor things like the obturator, I bring that up because it's right there. You can still walk without being able to adduct your leg. It might be a little weird, but you can do it and your function comes back. I've had patients come back and see me and that function gets completely restored. So you're not necessarily taking away their ability to ambulate, but you are taking care of their pain. So I look at imaging and then I try to come up with what's going on. Sometimes you just see a big tumor and it's not actually invading anything. And that's where your knowledge of possible targets, which would be pudendal, which would be impar, which would be superior hypogastric plexus, and then pelvic splanchnics, which sit anteriorly to the sacrum, which I've done a block of those before. You can't really ablate them because there's so much innervation to the bladder in terms of function for that. But you can certainly get some, and vagina as well. Vagina is more just sensation. But understanding what's down there and potential targets in your mind will kind of help guide your conversation with the patient. So most people will be like, oh, just do a pudendal. Well, if they're not having perineal pain or anal pain, that's not going to help you. Whereas if they're having some kind of vague anal or rectal pain or, some urethral pain, okay, from something else that's going on. Sometimes rectal tumors can tug at the posterior aspect of the urinary bladder. And I've seen people have some urinary symptoms from that as well. Then you want to think about impar, right? And, if it's a little bit higher and more kind of, pelvic pain or pressure, and that's just how they describe it, and it's deep, then maybe you want to do superior hypogastric plexus. But you have to talk to the patient and really make them usually the answer I get from patients is, I never really thought about it. I just had pain. It's this. And I'm like, okay, but no. And I make them tell me, is it pressure? Is it burning? Is it stabbing? Is it radiating? What makes it worse? What makes it better? What's your baseline pain? What is it when it gets to be its worst? And, if you have that baseline pressure, but then sometimes it turns into a shooting, okay, how bad is it? How bad does that get? And how often does that get? So not only does it help me kind of quantify their pain and give targets to measure for how they improve. So when a patient says, I still have pain, and I'm like, oh yeah, but this is better and this is better. And they go, oh yeah, it makes them happy because it shows that you've done something. It makes them more in tune with their pain. So if you do more future interventions, they can talk to you a little more informed and intelligently about it, which makes your clinic visits shorter and things easier. But it also gives you a better idea of what to target. And so that's typically how my initial visit would go, especially with the rectal cancer. And then you always start with the block, right? Block, diagnostic, therapeutic, cheap. And some of the things in the pelvis, you can't cryo. You can't get around to the superior hypogastric plexus. We're stuck with ethanol for that. And even then, liquid neurolytics really scare me. And they scare me because there's not as much control. I can't turn down the power of it. It can spread. Ethanol can destroy things and you can't get that function back. So you have to be very thoughtful in what you're doing. I think people, we've been very lucky to have something where you can allow the nerve to completely regrow, or the communication, and not destroy it and not end up with this terrible neuroma formation or worsening pain because you destroyed something. And the worst thing you can do is send somebody, make them worse off than they were, which I have. I've done with a rectal cancer patient before, made them worse off. I gave them a neuritis from a ganglion of impar cryo, and it's terrible. That's a great question. Trial by fire. So a lot of times, if the nerve itself is not abnormal and you cryo it, so like with splanchnics, if it get ice posteriorly and it touches an exiting intercostal or lumbar nerve root, or if you are doing ganglion of impar, and rectal cancer patients a lot of times will have radiation, and this is what happened with me. As I targeted that area, it seemed to correlate with his symptoms, and with the block, he got a lot of relief. And so when I cryoed it, it was more abnormality from the radiation, and he'd had like a massive increase in his pain in that reason. So know that when you have that kind of neuritis, it usually lasts 6 weeks and then it goes away. And it's about first week, if it's going to happen, it happens in the first week and it peaks. and it stays really bad. And about week 4, it starts improving. And then it pretty much goes away in general, very predictably. So what do you do? If it's, skin pain, you can do topical lidoderm patches, lidocaine. You can give them low-dose tramadol, steroid tapers, but also even like a dexamethasone taper. Oh man, people feel great on Dex. And interventional pain physicians do steroid tapers for patients who have chronic pain, and they feel really great. You have to be careful though if they're also on chemotherapy and already immune suppressed, or they have any open wounds or wound healing. But a steroid taper, doing 3 milligrams of Dex, BID, for a week, and then doing that 2 milligrams BID for a week, or even you can do a longer taper, will really, really, really help a patient through it, and also educating them. Also, sometimes even going back and doing a block afterwards with some local steroid will calm it down. And I had people ask me, like, why don't you just do a block and then do a cryo? And for me, I don't think it's a bad idea, but I think that may change the dynamics of what actually happens to the nerve, not only in terms of, freezing point depression, and going to get all nice and nerdy about that stuff.
Yeah.
And I'm like, all these
Gen
pre-med
Chem.
courses. Yeah, you're right. Like, when am I ever going to use this? That's like, oh yeah, like, here you go, freezing point depression, And so kind of like why you use D5 instead of, other things. D5, has a lower freezing point, lower point of absorption. So if you use that for hydrodissection, it sticks around longer than other things. And so you get freezing point depression with some of this stuff. Like, am I going to need to freeze longer? Am I not going to need to freeze longer? Is it going to change some of the biomechanics of the cellular membrane of the nerve or the myelin sheath, and it's going to alter it? I don't know. So I'd rather just bring them back and block it later.
Gotcha.
An issue.
Gotcha.
And then anti-inflammatories, massive. Meloxicam, huge. I've had patients who have really bad reaction to steroids, and I'll put them on meloxicam. And there's a good paper out, I think it's in JAMA, that talks about putting people on 7.5 of meloxicam up to twice a day, for sure once a day, for 6 months. And they had no higher incidence of gastric ulcers or issues with their kidneys, things that you typically worry about. And so know that you have that in your back pocket. And we only need it for 6 weeks. And so again, check a patient's renal function. I always put them on a PPI to make sure they're okay. But these are all great ways to manage a neuritis.
Super helpful. And I found that just having a multimodal approach is so important. And especially towards, I'm very averse to oral opioids, and I still have to use them from time to time, but mostly in, acute post-surgical situations. That's totally appropriate and where it's good to go. But I think having that approach, especially for something tricky like neuritis, and again, with the expectations for the patient, hey, this is going to get better. It's going to take some time. We'll bridge you through it with these different medications and try to attack it from different angles. One thing that I want to bring up that of course, shout out as usual. This happens probably about 2 to 3 times per episode to my mentor, Dr. Beal, introduced me to a new non-opioid pain medication on the market. It's called Journevax. It's a really interesting. It's a sodium channel blocker, and seems to work really well for these kind of acute pain episodes. I haven't used it in the case of neuritis yet, but it can work very well. And so I think that's exciting that we have something that is, another very powerful non-opioid medication.
Yeah. And I forgot to mention too, I do use Lyrica.
Yes.
Lyrica can be more expensive, but it has this nice little sedating effect if you take it at night. So it helps people sleep. And it's usually a little bit better tolerated than gabapentin. But as you mentioned, non-opioids, they can be super helpful in doing that. And I have not tried Journevax yet. I think due to cost and stuff, I kind of want to see what else it does. But being able to, again, give non-opioid options to patients is wonderful.
Fantastic. And so like you talked on, neuritis is one of these complications that we look out for. And frankly, even in just standard RF ablation, standard medial branch rhizotomy and stuff like that, or geniculars, I would always give, the way I was trained is always giving some steroid at the end of the ablation to kind of mitigate that. And so with cryo, it sounds like you're saying you cryo and then done. And then if there's something that comes back, you'll kind of do that. But neuritis is just one of these things that it absolutely has to be a part of the informed consent discussion. And I consider that, one of the very realistic, even though it's not overly common. It's still one of these things you have to treat as being very possible, and coaching the patient through that. What are some of the other major complications in these interventions that you look out for? Maybe you've dealt, maybe have not had to deal with, but still are wary of.
Well, Jacob, if you haven't had to deal with neuritis yet, you haven't been doing it long enough yet. And you keep getting rectal referrals, you're going to. I actually do want to touch on this because I had somebody tell me, you have people that don't like you. You have patients that are upset with you. You have patients that you haven't helped. And I do have one patient in particular I remember was a TACE who had pain and couldn't get a hold of me. And to that person, I'll never forget that conversation. It was a colleague. And I can ask any one of my patients, and they may or may not have gotten a positive result, but every one of them, I would say in general, feels like they went into it with eyes wide open, because we did discuss all the potential complications, risks, benefits of doing something that is fringy, of stuff that, doesn't have a lot of research by. But with that, they all have a way to get a hold of me all the time. I don't give out my cell phone number, but I give them my email, and I'm checking it all the time throughout the day. So through this neuritis, I have them reach out to me, and I check on them and I make sure they're doing okay. And so having really, really good, close patient care and letting them know I am here for you, I'm going to guide you through this if this happens, is so imperative to building a good practice and having success. So, but the neuritis, I would say it happens more than you would think. Depending on the areas and the ganglion you were talking about, which is, again, a topic for another time. The other major complications, I think that's about it.
Nice.
Honestly, that's the big thing. With cryo, because of the ice, it has this, we've seen the research on like osteoid osteomas, RFA, versus like using cooling, techniques. And cryoablation, they get immediate pain relief because of the lack of the charring and the coolness effect of it. And so my patients usually feel better immediately after, so I don't really see any need. And intraoperatively, I usually use anesthesia or monitor anesthesia care, and instead of using a lot of lido, I use bupivacaine, because usually it's 12 hours of like pain involved in the muscles I went through, other things, and I find that gets them a nice carryover to having some pain relief for that. And then the other complications, like retropharyngeal hemorrhage, hoarseness, stroke, pneumothorax, like stuff with the stellates. You can read the paper. Look at that.
Yeah.
But like all the risks that happen and that are they're really germane to the area that you are targeting. But in general, I think the biggest one that people don't know about or know how to handle is the neuritis, and you really need to be sure to educate patients on that and have access to other specialties that can help you through that. There's only so much you can do as an interventionalist in terms of pain management, medication management of neuritis. You need physical therapy. You may need an orthopedic surgeon to evaluate. Maybe you caused a brachial plexopathy. Maybe you need to get an MRI. Maybe, you're doing a case, and I had a case. I actually presented this in the early career section, and it was tough. There was a cryo I was trying to do on a patient, and I was doing the patient's leg and doing a tumoral debulking and trying to do the spinous process a little higher. And I had this nice drill, got a nice biopsy, was working my probe in there with the appropriate back tension. And the next image I take is the needle going across the spinal canal and the thoracic spinal level. And the last thing you ever want to do, and it's nobody's ever intention, is to hurt a patient. Mm-hmm. And some of the complications that can happen, as you're asking me, you don't know or you don't think about until you're in it. And if that happens, it's how you handle it. And I was working collaboratively with an incredible orthopedic oncologic spine surgeon, Dr. Rand Lador, who's at UT in Texas. And we had been collaborating on other patients. And actually, he was going to this patient for a corpectomy. And so I was doing some of this other stuff beforehand. And I was able to reach out to him. Like, I already knew. I get the MRI, check for the epidural hematoma, wake him up, make sure the patient can move. Got a CT on the table of the patient to see if there's any really, really bright blood I can see. But my next call was to my colleague, and who I knew I could support. And I really want to drive this home, as I think I do in every lecture. I think you do too, about the importance of having collaborators and the importance of a team approach to all this, because you cannot do it all. You can try, but that's why there are specialties. That's why people come in and say, don't you see this on this image? Da, 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 da. And I'm like, no, dude, that's the colon. That's not the uterus. Because you went through all this training. And so it not only offers somebody a different training, but also a different perspective and remove. By the way, patient ended up being completely fine. And the surgeon says, like, you do so much crazy stuff. I'm surprised that something like this hasn't happened before. And, you're fine. And so I think and then I immediately talked to the family and talked to them about the plan. We had a plan for follow-up and X, Y, and Z. And, I think that close patient follow-up, being honest, having collaborators, for those unexpected complications that can happen, can really help you out.
So important. And everything that you're saying just reminded me of something. It taking me back to med school, actually, at the Academic Interventional Radiology Conference back in 2017, 2016, maybe. I remember, and he'd probably be blown away if he hears this, that I remember that Kyle Cooper was talking about, who's an awesome interventional radiologist. And he was talking about when he was in his fellowship at Miami, one of the lessons imparted to him is, if your patient has a complication, you better become their best friend. And I think that's such an important philosophy. Some people kind of run away and extricate themselves from the situation. And we know that that's kind of the behavior that gets people sued, and patients, when they sue, it's not usually just because there was a complication. It was because how it was handled. And the patients who feel abandoned are, way more likely to do that. It's just not the right thing to do. I would want that for my family member. I'd want that for myself. Tell me, be honest with me, and, involve the other people, load the boat and get other people on board to help.
100%. It takes a community, it takes collaborators. And because IR constantly does fringy stuff, in order to be ethical, we need to educate patients on possible complications. And then in order to keep them safe, we have to be open to collaboration. We have to be able to communicate with them. And we have to know that we have to be able to be honest with our patients about what's going on. We have to tell them if we're doing something that's fringy, potential upside and downside. And if stuff happens, we have to be there for them. That is our job, is to be there for them. Not only for fear, I don't want to get sued, but I think also just because this is a person.
Yes.
And we did something to them. And it is our job to guide them through healing. That's literally the oath we took. And I take it very seriously, and I can tell you do as well.
Well, Dr. Levey, this has been a fantastic conversation. And I'd like to know, what other topics would you like to talk about before we close?
Spreading the gospel. Oh my gosh. So Julius Shapiro recently did a really great back table with you guys on HCC. One of my new colleagues, and he is fantastic and brilliant in his own right, and talked about the importance of literature and standardized care and making sure things are standardized across the board, and the importance of doing research behind it. So it's really great that we talk about all these things that we do in our own society, and that we're starting to educate people. And hopefully this paper is a jumping off point to start to standardize it. But we have to do better. We have to do research. We have to collaborate. We have to start presenting outside of SIR. And I myself am so blessed to be able to, have been able to publish in, JVIR, CVIR, now seminars, be on this incredible podcast, which I hope reaches more than just interventional radiology. But I have not, presented or even been to, ASRA, the main pain conference for anesthesia pain. I have not been to some of the sarcoma conferences like MTS, although I had a project I was on with some colleagues to talk about what we can do for that. Desmoid tumors. Oh my gosh, don't get me started. That was, I guess, on the other back table that I did. We need to do better about getting the word out there. And I think it starts at a local level. It starts with standardizing procedures, educating local people at your own institutions or community hospitals what you can do. And then talking with other people about, hey, like if this works and you think it's good, like how can we get the word out there? Or can we publish a paper together and let's try to get it in your journal and disseminate that? People in medicine in general, I don't think are going to pick up an interventional radiology journal. And that's usually who first sees these patients. So we really need to do better as a society at finding ways to disseminate this information when we are truly initially just the consultants and not the first pathway that patients come to.
Wow, really well said. So important. And I think we can kind of get desensitized to it at our meetings. We see these amazing cases and it's like, oh yeah, everyone's, ganglion impart, cryo and, cryoablation, tumor debulking and stuff like that. And you talk about this to, your friendly neighborhood oncologist and a lot of times they'll be like, what? So, yeah.
You want to do what to my patient?
Exactly. And so getting that out there where it's like, okay, and it's the same thing for interventional radiologists with DVT. It's like, oh yeah, iliocaval occlusion. Oh yeah, for sure. But for the average internal medicine doctor, hematologist, I mean, that's mind blowing to them. So I think we're a little bit desensitized to how amazing, and you use the term fringy a few times. I think we do have to acknowledge that. And so the effort that you're making to spread this out is fantastic. I think let's keep up the momentum. Really appreciate your drive to work on the research to get the support for this, because we know that we need that for these therapies to be viable going forward.
No. And thank you guys for supporting me, for giving me the opportunity to talk and help spread the word. And to Aaron, it really means a lot. I'm very honored to be able to speak about this. And I hope that if this just reaches one other person, then we've done our job.
Fantastic. Well, I agree. I think it's going to reach much more than one person. It's already reached one, and we'll kind of roll from there. So thank you so much for joining us. We'll definitely be having you back before long, and best wishes that you get acclimated to your new colder home.
Thank you so much. Appreciate it.
All right, thanks. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable MSK on Instagram, X, or LinkedIn. Backtable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.